Well, you just can't monetize the interview or the other than that, you can still play it. He'll get a royalty anyway. He deserves it.
Trisha, I think we might be live now.
Yeah, it looks like we are.
Okay,
Thank you, Trisha.
welcome.
Trisha, can you make me a co-host and then Kirsten the host before you go?
Yes. Okay, you should be all set.
Thank you.
Okay, bye.
Bye.
Okay. Thumbs up from both of you ladies. Okay. Good morning. I am Senator James Gray, the Vice Chair of Health and Human Services, and I guess the acting chair because the chair is has some duties other than here. Today we will be having public hearings on two House bills and an amendment. House bills are 143 and 187. Before we get started, I will read through the checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As the acting chair of Health and Human Services Committee, I find that due to the state of emergency declared by the governor and as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order 12, pursuant to Executive Order 2020-04, and its extensions, this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I'm confirming that we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom webinar for this electronic meeting. All members of the committee and select legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch or listen to the meeting on Zoom and YouTube and via the phone, following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us or call area code 603-271-6931. In the event the public is unable to access the meeting, we will adjourn and reschedule. Please note that all votes taken during this meeting shall be done by roll call vote. Finally, we will start the meeting by taking roll call attendance. When each member states their presence, please also state where you are and if anyone else is in the room with you during this meeting, which is required under the right to know law. I will call the roll to start the meeting. Senator Avard.
Senator Avard here in my office in Nashua. I am alone in the house, a couple of barking dogs. Other than that, by myself.
Senator Sherman.
Senator Tom Sherman, District 24. I am at my house in Rye. There are family members here who may pass through the room.
Senator Whitley.
Good morning. This is Senator Becky Whitley at my home in Hopkinton. I'm alone in the room, but my husband is in the house.
And as noted previously, Senator Bradley is at a meeting and will join us as soon as he's able. I am Senator James Gray. I'm in my office here at the State House, and I'm alone in this room. All right. That being said, does anyone have any comments or anything before we call the first bill, which is House Bill 143? Seeing none, if you'd ask the prime sponsor to join us. Good morning, Representative.
Good morning, Mr. Chairman. And good morning to the band players of the Senate committee.
Good morning.
So today I come before you in the members of the committee to introduce House Bill 143. For the record, I am Representative Gary Merchant, representing Sullivan County, District 4, Ward 2 in Claremont, New Hampshire. I did provide written testimony before. This is my verbal. Basically, House Bill 143 is a simple bill with two primary components to it. One is dealing with statutory language holding software companies accountable and liable for deceptive programming, electronically prescribing prescriptions for narcotics and controlled drugs to assist the state in tackling the opiate crisis. Those are the two primary components to the bill. Deceptive programming, why is it in the bill? In January 2020, Allscripts Practice Fusion agreed to pay $145 million to resolve a criminal and civil investigations by the Department of Justice related to an illegal arrangement with a major opiate manufacturer. Practice Fusion received payments from pharmaceutical manufacturers to create and implement clinical decision supports used by providers to make clinical decisions. Practice Fusion alerts encourage providers to evaluate the patient's pain. When a patient's pain hit a certain level, the program generated an opiate therapy treatment option that included drugs manufactured by pharmaceutical companies who had provided payments to Practice Fusion. The language incorporated in the bill addresses this concern by adding language to the Consumer Protection Act to address such deceptive practice. The other part is electronic prescribing of controlled drugs. For the past several years, according to the 2020 New Hampshire Drug Monitoring Initiative, more than 400 individuals have died each year for the past several years from a drug overdose, a sad reality. The state has undertaken multiple initiatives the past several years to address the opiate crisis. However, fraudulent prescriptions remain one of the last avenues available to obtain high-quality legal narcotics and controlled drugs. Written prescriptions provide an opportunity for an individual to manipulate the number on a prescription pad by simply adding a 0 to a 10, making it 100, or a 0 to a 4, making it 40, or changing the number 10 to a 40, or 30 to an 80. Individuals steal provided prescription pads from clinicians' offices or clinics, and the more ingenious individuals find ways to make their own pads or illegally purchase them. This past quarter, as a pharmacist, I received 2 alerts of stolen prescription pads. In 2019, while serving on the New Hampshire Board of Pharmacy, the board received notice that a hospital employee had obtained 20 prescription pads equal to 22,000 individual blank prescriptions to write their own prescription. In my experience as a pharmacist, when a patient goes to multiple pharmacies, the primary reason is not to find the best price, rather is to find a busy pharmacy or pharmacist to deceive. Electronically prescribing a prescription provides a secure, direct link between the prescriber and the dispenser, avoiding the opportunity for an individual to alter the prescription or use a stolen prescription pad to illegally obtain narcotics. The Medicare Modernization Act of 2003 included a provision for electronic prescribing of medications, which provided national momentum for e-prescribing. To address the opioid crisis, Congress passed the SUPPORT Act of 2018 to require e-prescribing of controlled drugs paid for by Medicare. The implementation of federal law will occur on January 1st, 2022, in less than 9 months, which is the actual effective date of this bill. Why does New Hampshire need a state law when the federal law will soon require e-prescribing of narcotics or controlled substances? Federal law only applies to Medicare prescriptions, which account for 40% of the prescriptions, leaving a majority of pain medications subject to fraudulent written prescriptions. This bill does not prevent patients, including those without insurance or uninsured, as they can still ask for a written prescription for more than 90% of the medications used to treat chronic conditions as blood pressure, diabetes, and cholesterol. On behalf of the 400+ families in New Hampshire who last year experienced the loss of a loved one related to a drug overdose, I ask that you support House Bill 143 to close the last remaining avenue to divert narcotics and controlled substances. That is House Bill 143.
Okay, thank you. Questions from committee members? Seeing none, I guess my list only had Ms. Minahan signed up to speak, and so I guess she's next. Welcome, Paula.
Good morning, Chairman and members of the committee. Thank you for the record. My name is Paula Minahan, Senior Vice President, State Government Relations for the New Hampshire Hospital Association. We are in strong support of House Bill 143. I did submit my testimony. I actually found a typo this morning, so I sent Kirsten corrected testimony. But this bill was this similar bill was passed by the House last year, but unfortunately didn't make it over to the Senate due to the pandemic situation. So I just wanted to be on record that the hospitals in New Hampshire are supportive of requiring electronic prescribing for controlled substances. In fact, many of the hospitals already have implemented such a program. Others are in the midst of implementing it. And as Representative Merchant indicated, it will be required by Medicare, but not that does not cover all the other prescriptions that are written, so necessary to have a state law. And the reasons for moving to electronic prescribing are compelling to include the safety and quality of prescribing processes, reducing errors, supporting clinical decision-making, notifying the clinicians of allergies, drug interactions, duplicate medications, and other clinical alerts, monitoring how many controlled prescriptions a patient has received, enhances communication between the prescriber and the dispenser, and reduces theft and increased security, which I believe Representative Merchant touched on all of those. So that's my testimony. Thank you for the opportunity, and I appreciate, I'm happy to answer any questions.
Okay. Are there any questions from committee members? Seeing none. If anyone wants to speak, please raise your hand. We're getting to the end of the list. If there's anybody else on the list, Sonia, we'll take them and then we'll look for the hands.
So that was everyone who had signed up to speak. I am not seeing any hands for House Bill 143.
All righty, then we will close the public hearing on House Bill 143. And as soon as you ladies are ready, we will open the hearing on House Bill 187. And I'll bet I can even find a sign-in sheet for 187 if I look.
Good morning, Senator Gray. This is Representative Marsh. Do you want me to introduce the bill?
Just as soon as Sonia's ready.
All set.
And, okay. Representative Marsh, welcome.
Thank you, Mr. Vice Chair, and it's a pleasure to see your committee again. For the record, I'm Representative William Marsh, representing Carroll County 8, 7 towns in Southern Carroll County. And I'm pleased today to offer for your consideration House Bill 187 relative to the emergency powers of the Commissioner of Health and Human Services. As you all know, this bill passed Health and Human Services and Elderly Affairs 19-2, in the House 333-6. It then passed House ED&A 17-1 in the House a final time on a voice vote. This bill does not address the governor's emergency orders. Other bills do that. This bill addresses emergency orders from the Commissioner of DHHS, of which there were 2. On April 3rd, the Commissioner issued an emergency order regarding the prescribing and distribution of chloroquine to treat COVID-19. On September 1st, she rescinded this emergency order. The bill also deals with various powers under the public health and infectious disease laws. Let me go through the bill and hit the highlights. On page 1, lines 13 to 14, we strike the phrase "and any other law to the contrary." The role doctors and nurses played in the Holocaust is troubling to me. It bothers me that emergency orders could in New Hampshire supersede certain criminal laws. Not that I believe our current commissioner or anyone else that we would approve would ever be involved in such a process. Page 1, lines 17 to 23, you can see current law, which I believe was appropriately used to limit the distribution of hydroxychloroquine under the emergency order. But I am not convinced the legislature intended to give power to the commissioner to prevent the prescribing of a drug medical professionals had reason to believe might be effective. Changing restrict to prioritize and adding lines 24 to 25 clarified that we are not granting that power. During bill drafting, the need for input into the vaccine distribution plan became evident. Reviewing the statute, I saw that we had an existing ethics committee, so I called John Williams and asked who was on it. He told me there were no current appointees, but the governor subsequently reconstituted it. To be ready for the next pandemic, this is referenced in lines 26 to 29, and we'll discuss this further in section 2. Page 2, lines 16 to 17, we are changing none of the language of the existing statute, but changing the reference. The language of the current statute clearly states an individual may refuse treatment, but the current reference to RSA 141C 15 Roman 6 states any law enforcement officer shall take such an individual into custody and transport the individual to the place or facility where the treatment is to be provided. RSA 141C 16 clearly gives individuals the right to refuse treatment and remain in quarantine. RSA 141C 20C are the grounds for refusing vaccination. Page 2, line 29 and onward is new language. One of our objectives is to make sure emergency orders are subject to a legislative oversight. HHS oversight already exists, so we did not need to create a committee for this purpose. This section was rewritten by the eDNA committee to mirror the process of final objection to rules followed by JELCAR. Peter Schmidt explained to me in eDNA that the final objection process is almost never used, but it is there for a very good reason, that being that our legislature does not grant any individual the final authority to make law on any subject. That should apply to emergency orders as well. Section 2 of the bill is a rewrite of the ethics committee established for H1N1 to accomplish 4 things. 1, the committee should actually have appointees and exist when it is needed. By appointing legislators to the committee, we can make sure that that will happen. 2, the committee should review investigations, orders, and treatments ordered to make sure that they are done appropriately and fairly, and this will be done with aggregate and de-identified data. 3, last year's HHS and EA committee was contacted by an individual representing a disabled individual who felt their rights were violated as a mask order prevented them from getting needed medical care. They couldn't see a doctor to get a note saying that they didn't need to wear a mask because they couldn't wear a mask it was catch-22. We discussed having a commission to address such concerns, but the existing ethics committee already in statute seemed a more logical place to send these concerns. Number 4, the governor used the State Disaster Medical Advisory Committee to reconstitute the Ethics Committee to create the vaccine distribution plan. When the plan was created, there was not the data we now have showing that current vaccines significantly reduce the spread of disease. If there were, it would have been debatable whether the vaccine should first be deployed to protect the most vulnerable in society or to interrupt the vectors that spread disease. Section 3 addresses membership changes to HHS oversight in last year's HB 1245 on page 9. In the House, we did not believe these changes were intended to remove minority party input from HHS oversight, and this section undoes those changes. We left it to the Senate to change their membership if they so desire. And last, regarding Amendment 1242S, I recognize the shortage of mental health practitioners in New Hampshire, and I am supportive of those new sections, allowing these individuals to practice under supervision so that the clinical need can be met. Thank you, and I'll be happy to take questions.
Okay, just a couple of things. People who want to speak on the bill itself, please raise your hand so that Sonia can identify you. We will take questions on the amendment after. And Senator Bradley, if you'd state where you are and if you're alone in the room, and then you can take over. But you have to unmute.
Thank you very much, Senator Gray. Pleasure to be here. I'm in the Senate offices and I am alone, although the door's open. So thanks for running the show. And Kirsten, go ahead with anybody or Sonia who wants to testify on the bill, not the amendment.
We had questions from the senators first.
Oh, okay, Senator Sherman, I'm sorry.
So I just had a clarification. I didn't fully understand, Representative Marsh. You made a comment about the use of CEDMAC, the Crisis Standards of Care Committee, and vaccines. How would this bill change who would actually have advised in making that decision?
Actually, it puts in statute the process that we actually ended up following. That committee was used to reconstitute the ethics committee that was already in statute, and that committee did make the policy, and I believe they did so appropriately. But this way, it would be clearly in statute what to do if a new treatment or vaccination for a disease causing a public health emergency came out, and we had to make a plan for distributing it. And that way, we wouldn't have to make up what we were doing on the fly. We'd already have it in place what we would do.
Follow up?
Follow.
So the only concern I have is I actually served on CEDMAC, still do, because we still exist. And the makeup of that committee was just an amazing amount of expertise from across the state in every aspect of healthcare, public health, health delivery. And would this mean that we would use legislators and appointees to an ethics committee to make the decision about how to manage a pandemic?
Well, as the governor said with his emergency order that reconstituted this committee, he intended to make sure he followed the guidelines that the legislature had put in place for the ethics committee. And I believe that the people that are listed as appointees under existing law, which we didn't change, except to add legislators to it to make sure it existed, are, as you say, a very qualified group of individuals and appropriate for making such a plan.
Okay, thanks.
Are there further questions of Representative Marsh? Seeing none. Thank you very much, Bill.
Thank you.
Okay, next we have John Williams.
Good morning, John. How are you?
Senator Bradley, I'm doing very well, and good morning to you, sir, and also to the members of the Senate Health and Human Services Committee. Also testifying with me today will be Attorney Melissa St. Cyr. She's our Chief Legal Officer for the department, and Melissa is going to take lead on going over the department's concerns and why we oppose certain sections of the bill as currently before the committee. So if Ms. St. Cyr, our Attorney St. Cyr, could be allowed to proceed, that would be wonderful.
Good morning, Melissa. How are you?
Good morning, Senator Bradley. I'm well, thank you. Thank you for allowing me the chance to speak today. For the record, my name is Melissa St. Cyr. I am the Chief Legal Officer for the Department of Health and Human Services. And I would like to speak today in opposition to just certain sections. We don't have concerns with most of the bill, but there are certain sections that we have concerns with, and I'd like the chance to speak today on those. Those certain sections are on page 2, lines 31 and 32, where the committee has the committee, which is referencing the Health and Human Services Oversight Committee, may have the ability to vote and sponsor a joint resolution rescinding an emergency order that would be issued by the department. And then paragraph 10, which is on page 3, lines 4 through 15. Those also the process and all of that. Those are our biggest two concerns. So first, I just want to point out the purpose of the Health and Human Service Oversight Committee in RSA 126A 13. The Oversight Committee is a Health and Human Service on Health and Human Services, shall provide legislative oversight of the department to support cost-effective, comprehensive, and coordinated system of health and human services that is family-centered and community-based. The committee shall promote greater efficiencies by consolidating and centralizing reporting requirements and other responsibilities of the department under the section to avoid duplication of efforts involving other non-regulatory boards, commission councils, advisory committees, and task force. We believe that the Health and Human Service Oversight committee has been a vital piece of the system and allows for accountability and collaboration with the department. It also helps address concerns by constituents. But the Health and Human Service Oversight Committee is an oversight committee, not an executive branch of government. There are, as you know, 3 distinctive branches of government, and the legislature has the ability to create laws, and the executive branch is there to execute and enforce those laws. And to allow the legislature to rescind an order by an executive branch is something that exceeds their authority and is a separation of powers issue. As Senator Sherman identified earlier, there's many experts that were on the SDMAC, and there's a lot of experts that are in public health. Public health are the experts in their field. The purpose of public health is there's so many purposes of public health. Many of those purposes include assessing and monitoring population health status, investigating and diagnosing health problems, strengthening and supporting and mobilizing communities to partner to improve health, assure effective systems that enable equitable access to individual services, and improve innovative public health functions through ongoing evaluation, research, and I think the most importantly is addressing and implementing strategies to respond to public health emergencies. To respond to these emergencies, the department must have the ability to address incidents that threaten the public health head on. The department relies on its experts with guidance from our federal partners, such as the CDC and CMS, to make the best decisions it can at a crucial time it's needed. Those decisions are vital to ensuring the public health and cannot be prevented from implementing, awaiting approval, or potential rescission from the legislature. So on page 1, lines 3 through 8 of the bill, I'm sorry, I'm trying to turn to that. Lines 3 through 8 it basically says that under 21P, the public health powers and duties of the commissioner is to, it's subject to the direction and control of the governor, but they're in addition to the powers that are under RSA 141C, which is our public health enabling statutes. And paragraph 1 of that, which is lines 9 through 11, says that the commissioner has the responsibility and authority to carry out all public health activities. So currently, the way the language is written, all paragraphs, including this paragraph 1, which is every public health authority and responsibility of the department, would be subject to paragraph 8, which I mentioned earlier, the rescission provision, the ability for the legislature to have a joint resolution to rescind an order. And so subjecting every order issued by the department to review is extremely problematic and could be dangerous to the public health. Section 10, which is on page 3, beginning on line 4, as I stated earlier, that the department would be prevented from enforcing. So that paragraph specifically prevents the department from enforcing an emergency order if HHS oversight votes to sponsor a joint resolution to rescind an emergency order. As I said earlier, delay in enforcing such an order can affect the lives of the public. It is extremely important that the department is able to issue orders and act swiftly to address significant public health concerns, and not being able to enforce that order would have lasting effects on the public. I would like John Williams to briefly go through, if Senator Bradley doesn't mind, the areas in which we think if just a few strikeout of sentences and language would make this bill obviously stronger in our view. So if that would be acceptable, Senator Bradley, I'd like you.
Sure, go ahead.
Senator Bradley, thank you. And Attorney St. Cyr, thank you as well for that very cogent overview of the current process and how this would significantly take away from the department's ability to be nimble in response to public health incidents. So Senator Bradley, I had provided just very recently to Ms. Koch, certainly for distribution to your committee for its consideration, the language that we would request respectfully to be struck from the underlying bill for HB 182. And we've also highlighted the sections for removal just so it would be there for some level of clarity. So as Attorney St. Cyr pointed out, the most problematic portion of the bill that we are opposing, it starts on page 2, lines 31 through 32, and it's a sentence that reads as follows. The committee may vote to sponsor a joint resolution rescinding the emergency order pursuant to RSA 21P:53, paragraph 10. And so we would be requesting the committee to strike that language. The remainder of that paragraph is certainly fine and appropriate, and we did appreciate the efforts that were made by the bill's prime sponsor, Representative Bill Marsh. He did have the courtesy and consideration to letting the department know of his thoughts, and he certainly at least heard our concerns. And I think that based upon the remainder of the drafting, that it shows it's reflective of what is reasonable, which is that the commissioner would then provide notice to both the Ethics Oversight Advisory Committee, the new name being proposed in the legislation in Section 2, and also the Joint Legislative Committee on Health and Human Services, which also makes sense to keeping them informed into receiving appropriate input from the committee, but not rescission authority. So if there are no questions on the changes that we're requesting on page 2 on lines, the deletions on lines 31 and 32, that now takes us to page 3, Senator Bradley. And the paragraph Roman 9, the department is fine with that paragraph. It is the paragraph 10. Now, of note, it was a Scribner's error, a very rare one for the Office of Legislative Services, because they do a tremendously good job. But paragraph 10, you'll note in there, is in regular text. It should actually be in bold italic, because this is new language. This is not existing language. This was added at the second committee in the House by the House Executive Departments and Administration Committee. And this entirety of this paragraph, we're requesting that that also be struck from the bill as it came to your committee. And as you read through the very elaborate process that's required if you were to go through a joint resolution, it's very clear when you read the timing issues regarding the 20 business days beyond this and the 90 calendar days for this, that if there was a rescission, it would not allow for a more timely reissuance of an executive order, because it certainly ties the hands of the commissioner significantly over large periods of time and putting the public at risk. And so we would request that paragraph the new paragraph Roman 10 be struck from the language. As to the remaining parts of the bill and Section 2, Representative Marsh did work with the department, and we actually were able to provide some commentary to him from our Division of Public Health Services working with him. And we were fine with the suggested changes that he had made relative to membership, and also notwithstanding some of the concerns that Senator Sherman raised, which certainly will defer to this committee on its judgment around that. But the remainder of the scope and responsibilities of the Ethics Committee, we thought were helpful in nature, and we appreciated the work of Representative Marsh around that. As that now takes us to Section 3 of the bill on the very last page, on page 5. And as Representative Marsh pointed out, there was Omnibus HB 1245 from the 2020 session, and included in it was the recommendations by the Committee on Committees that were either eliminating or changing certain committees. And through belief, inadvertence, because it was something that I did not see, nor did other members of the Oversight Committee at the time see, but they had reduced the membership from 8 to 5. And Senator Bradley, you served on the HHS Oversight Committee for many years. And certainly we would just respectfully ask for your consideration to restore the Senate membership to 3 members in the Senate, because it's worked extremely well. And as you'll see, and that request would be made on page 5, line 11. So on page 5, line 11, we request that the 2 be struck, and inserted in place of that would be 3. That's also reflected in the draft amendment that was provided to Ms. Koch just very recently today, and certainly is available for circulation to the committee. Again, the department opposes these specific sections that we referred to in Section 1 of the bill relative to rescission authority. As to the remainder of the bill, we are fine with it. And in fact, as to Section 3, supportive of the changes to restore the HHS Oversight Committee to its full complement of 7 and hope to be 8 members, including an additional member from the Senate. So Senator Bradley, that completes my walkthrough.
Okay. Are there questions of the department? Okay. Thank you very much. You'll stay on for if there are further questions, hopefully. Thank you both.
Thank you, Senator Bradley.
Thank you.
Okay, we have one other hand for the bill, and it's Representative Edwards.
Good morning, Representative.
Good morning, Representative Bradley and members of the HHS Senate Committee. I'm Representative Jess Edwards from Auburn, and I am a co-sponsor on FB 187. And I just, after hearing the testimony, I just wanted to add to the discussion the thoughts and theories that each member of the Senate committee is already familiar with, but it's worth reminding people that our system of government relies on checks and balances. There's a general assumption built in that no one department, no one individual should be trusted with absolute power. And so there was an explicit effort to distribute that power amongst various entities so that it couldn't be consolidated or abused. And as much as I respect the Department of Health and Human Services, they are people too. They are not infallible. And to the extent that there should be a check on that power, I think it's important for us to figure out how to do it. If the issue is that it's not being done properly, then we should fix that. But I don't think there should be any question of whether or not checks and balances are appropriate, particularly in light of the New Hampshire Supreme Court ruling that said during a state of emergency, all citizens of New Hampshire may have their civil or constitutional rights suspended in order to appropriately deal with a public health crisis or other state of emergency. So because we're loaning tremendous power to the executive branch, I think we need to be judicious about the idea that there may be a future point where the legislature needs to be able to step in as the people's representative. The department obviously gets focused on public health. They're not the entity charged with the entire scenario of what's best in the best interests of our society. They don't have economic concerns, for example. They don't have freedom of worship concerns, for example. They have strictly a public health concern. And so the legislature is the people's representative and is the branch that's really accountable for the maintenance of the entire society. I would just encourage the committee to just respect the founding principles and find a way to get them implemented and protected for future scenarios. So that's my testimony. Thank you very much.
Okay, thank you very much, Representative Edwards. I think that Senator Avard has a question.
Yes, thank you, Mr. Chairman, and thank you, Representative, for coming to the hearing and talking about this. I just one concern that the legal advice just brought up was the fact of the separation of powers, page 2, lines 31 through 32. I'm just concerned that is this going to be a headache in the future in that if the legislature says, well, no, the executive branch can't do something, is there a separation of powers situation that we're going to have to deal with? Did that make sense?
Is that a question for me? I don't know who the question is addressed to, Senator.
To you.
To you.
Yeah, well, on page 2, lines 31 through 32, it was brought up that there might be a conflict of separation of powers, a problem with that, with the legislature interfering with the executive branch. Can you comment on that?
Yes, sir. I think if that's for me and not Senator or Representative Marsh, I'd say that we inherently accept that there can be conflicts when we separate and delegate different powers to different branches. And so, so that's a cost of doing business in a free and open society that I think exists even in a state of emergency. And so the issue to me isn't whether or not there is a cost associated with having a check on the system. It's more a question of whether in the judgment of your committee that that cost is fairly balanced against the benefit of unchecked power. So, so it's a trade-off. Obviously, you know, people who have power think they can use it appropriately and fairly, but we decided hundreds of years ago that we don't loan total and comprehensive power to any one entity. I hope that answers your question.
It answers the spirit of the question. I think if I may have one follow-up, Mr. Chair, who authorizes the emergency powers? Is it the executive branch or is it the legislative branch?
I would like to defer to Representative Marsh if possible, Senator.
Thank you.
Are there further questions of Representative Edwards? Seeing none. Thank you very much, Representative.
Thank you, Senator. Thank you all.
Senator Avar, do you have a question of Representative Marsh?
Basically, if you could answer those questions with regards to the separations conflict that we just discussed and who also authorizes the emergency powers in the first place. Is it the executive or is it the legislative?
Thank you, Senator. I missed your first question because I took my headphones off and answered a telephone call. You might have to repeat that. As far as the second question is concerned, the legislature has given the executive branch authority through 21P to issue emergency orders by the Commissioner of Health and Human Services. So it's derived power from the legislature. Unlike other emergency orders, that provision in existing law does not have any provision for ending a state of emergency or ending an emergency order. There's basically no check whatsoever under existing law. So the debate through the House has been, how can we effectively have a check? Because we sincerely believe that at the end of the day, the legislature does need to have a check on the executive branch, basically in all instances. And the final debate in ED&A, which I thought was actually a very good debate, was that following the same process as the legislature currently uses when the department issues rules, there's a process for final objection, which basically doesn't have to be used because everybody stays at the table because they know the process is in existence. It is a reasonable check and has been well established in usage in other ways. And if we use that same procedure here, it would be appropriate.
And the first part of my question, Representative Marsh, was basically on page 2, lines 31, 32. Again, the separation of powers, and that is drawn up as a situation of potential conflict, and they're asking for this to be removed. And your thoughts?
Well, I understand the department's objection. I think the limitation of powers has been a subject of conflict in governments for thousands of years. People don't like to give up power ever. And in fact, this would be the legislature taking away a power from the department. There's no doubt about that. And as I've told Mr. Williams, I totally expect him to oppose that just on general principle. However, I think it is totally appropriate that the legislature is the final authority as to what powers it has given to the executive branch. And if the two come into conflict, there needs to be some kind of mechanism for resolving this conflict. And here we've tried to propose a mechanism that I believe would work.
And one final question, if I may, Mr. Chair. On page 5, line 14, 5 members of the House versus, and 3 members of the Senate. What is the logic behind that? Why did you change the number from 3 to 5 and then from 2 to 3?
Well, the reason we changed the House members is the Senate sent us an omnibus bill last year where they changed the House members and the Senate members, and the House didn't like having its membership changed, so we changed it back. We figured that if you guys want to change your membership back, you can do so, and if you don't want to do so, that one's entirely your call. We will concur with whatever you have to say on that matter.
So nobody likes to lose their power. So, all right. Thank you very much.
Senator Sherman.
Yeah, thank you, Mr. Chair, and thank you, Representative, for taking my question. The concern I have about these lines that that have been outlined by the department is that when you're in the middle of a pandemic, you and I are both physicians, we know how quickly we have to respond. We also know how quickly rulemaking responds, which is not quickly. Even emergency rulemaking can be cumbersome. So would you not agree that the oversight for the commissioner is with the governor, and the governor is held accountable for the actions of the commissioner, and that would fit into the separation of powers, and the commissioner is the appointment is approved by the executive, the council, and so there already exists significant oversight within the executive branch. And to put this in, my biggest concern about having this in there is, and this is the question, is would you not agree that the key to combating a pandemic, and we saw this back in March of last year, is the ability of the Commissioner of Health and Human Services to act swiftly, to be able to act with confidence based on the best science available in the interests of the public health. And my concern about putting this in there is that this is beyond a speed bump, and it's potentially could hinder for up to 3 months the ability of the executive branch to respond to an emergency. Would you agree with that?
I would not agree with that statement in its entirety. I do agree that speed is of the essence. And I believe that a commissioner who is taking reasonable steps would be able to convince the group that is on HHS oversight, which is a fairly carefully selected group. I think we'd all agree with that. They're people who are generally reasonably well informed on such matters as involve the Department of Health and Human Services. And I think that as long as the commissioner is taking reasonable steps, that this would present no obstacle whatsoever to acting swiftly. Now, the analogy comes with emergency rulemaking, as you say. If the commissioner wants to institute rules by the emergency process that are objectionable, the legislature has said that they can't enforce them, but they don't go away. And then the commissioner is then in a position where they need to defend in the courts whether what they're doing is reasonable or not. And the third branch of government settles the dispute. There's already established procedure in place when that happens. It doesn't come up very often. At least this is how Peter explained it to me in eDNA, and it sounded reasonable. So I think that in the event that the commissioner is not able to convince HHS oversight that what they're doing is reasonable, which I think is going to be exceedingly unlikely in the first place, and that comes about in the interim time when a joint resolution will be being considered, their emergency order is still there. We have said they can't enforce it, but the courts are ultimately going to decide whether they can enforce it or not. And that would be the same procedures as would be under emergency rulemaking when there's a final objection.
Follow up?
Yep.
So help me with this. Are you saying that here you are saying they cannot enforce that order as long as the joint resolution process is in place? So in order in the face of an emergency requiring a nimble and just a swift response, could be 24-hour response. If this committee, which is a politically appointed committee by either party, if this committee objects for whatever reason, they could force the department, in order to enforce this emergency order responding to a crisis, they could force them to go to court.
The public can already force the department to go to court. There was a court case last spring against the governor, as we all know. So I think that's already in law, and I don't think that anyone would suggest taking away the right to take cases to court.
Further?
Of course, I'm not suggesting that, but what happens with this process that you have in this bill, and so my question is, am I correct? What happens with this process is the order is issued, the resolution is called for, the order cannot be enforced. In the current system, the order is issued, it's in place until a court decides that it cannot be enforced. So essentially what you're doing is any objection by the legislature resulting in a resolution would then not allow enforcement of the order until that is either resolved by the joint resolution or by the courts. So there is an automatic, in this scenario that you've painted here in this bill, do you not automatically create a potential roadblock to an essential emergency order that, for potentially political reasons, is objected to by the legislature rather than based on the scientific evidence and the medical rationale?
Senator, I hear what you're saying, and I don't agree that that's the correct conclusion. And the reason why is what we did is we copied the language from the rulemaking process, and already in place, we know there's historical precedent where JLCAR has objected to rules, and the rules have ended up in court, and the court has decided whether they are enforced or not during that period of time. Now, if you want to change the language from the JLCAR language, instead of saying cannot be enforced, say the court shall decide whether they shall be enforced, I'm totally okay with that too. I just think that at the end of the day, there needs to be a check and balance.
One more.
Actually, I've just, I guess it's a parliamentary inquiry. When we are done discussing this with Representative Marsh, if we could have John and Melissa back, that'd be great.
Okay. All right. Thank you again, Bill.
Thank you. I'll stay on the line.
Okay. So Senator Sherman has a question of Melissa St. Cyr.
Hello, Senator Sherman.
Hi, Melissa. Thank you. I'm essentially am just trying to figure out the practical implication of this section of the bill that you're objecting to and that Representative Marsh is stating is fine and that it would not delay any implementation of an emergency order in the face of a critical pandemic.
So I respectfully disagree with Representative Marsh. Obviously the department, as I testified to earlier, must be able to respond in the face of a public health emergency. Our ability to act swiftly is what our powers are, why our powers were granted. And I understand his point related to powers and the separation of powers issue, but the legislature has granted the department, and specifically the Division of Public Health and our commissioner, the power to address certain concerns related to a public health emergency. And in this, in then granting us that power, but then questioning that power that's been granted to us, is not necessary, is the issue. It's not necessarily the fact that we've been granted the power, and it's not that we don't want control or that we don't want to give up that power, but that power was granted to us specifically to address public health emergencies and to address things that may threaten the public health. And we need to be able to do that and do that swiftly to protect lives. And that's really our main goal. And if we're not able to do that and we're stopped from being able to enforce any type of emergency order that has been in place to protect the public health, then it could risk people's lives. It's very dangerous. And so that's where our concerns are.
Thank you.
Senator Avard.
Thank you, Mr. Chair. And Melissa, thank you. I'm just curious if there's a perception that there is an abuse of this emergency order, can the legislature rescind the emergency powers at any time?
The legislature would have to go through the process to amend the statute to withdraw our power. That would be the appropriate process.
Further questions?
Thank you.
Okay.
So Senator Bradley, that was all the hands we had for the bill itself.
Okay. I don't think, if there are no more questions and no more hands raised, I think we will move on to introducing the amendments. So Senator Gray, do you want to run this portion, if you don't mind? You're muted now, Jim. Jim, you're muted.
I'm just realizing how badly I did that. So we'll take the prime sponsor of the amendment, Senator.
All right, thank you very much. Senator Whitley is also going to introduce this, but let me just thank, obviously, all 5 of the committee members who have, on a bipartisan basis, agreed to sponsor this amendment. It was brought to us by Michelle Merritt of New Futures, and I think Michelle and many others have been very vocal about the need to get more qualified mental health workers at a bachelor's level, entry level positions with the appropriate level of supervision into New Hampshire. I always talk about 3-legged stools. We clearly have to have the appropriate infrastructure in place, buildings, that type of thing. There's a debate about a secure psychiatric unit. That's a debate that should happen. There is a need for funding to make sure that we have the resources available for mental health treatment. But none of that will work. All the money in the world, all the facilities in the world, if we don't have a qualified workforce. And we know from testimony that this committee, quite frankly, has heard for several years that we need to enhance our workforce. And so allowing entry-level bachelor's credentials with appropriate supervision for mental health workers, I believe, is absolutely appropriate. This is something similar that was done for LADACs when we authorized and licensed LADAC. So it's not a new concept. And Mr. Chairman, I would indicate that according to Ms. Merritt, 38 other states allow this kind of bachelor level entry personnel to be able to, with appropriate supervision, begin that process. And we need those folks, hopefully, to be licensed here in New Hampshire. That's what the amendment seeks to do. I really appreciate, again, the co-sponsorship of all of you on the committee. I think there will be some questions raised by carriers that have come to both myself and Senator Whitley. I think that we can address those. But this is, if we are going to really try to not only resolve the ER boarding crisis, but mental health situation in general, we have to take this step to get more qualified people in New Hampshire working on this issue. So I'm going to stop there and turn it over to Senator Whitley, who had a lot to do in the crafting of this amendment.
Before Senator Whitley gets just a procedural matter, anyone who wants to testify on this amendment, please raise your hand so that Sonia can identify you when we get to you. And Senator Whitley.
Thank you, Mr. Chair, and thank you to my fellow committee members for co-sponsoring this amendment. So, as Senator Bradley indicated, we know that our mental health crisis and our substance misuse crisis, it's really complicated. This committee, this body has been working on it for many years, and we need to continue to look at it from all different angles. We need multi-pronged solutions. So over the last few years, bipartisan efforts have infused money into the system, needed resources to start building up our community-based system of care to keep folks out of the hospital and out of the ERs, and to get folks out of hospitals and into appropriate settings. And, we've done that by building new services like mobile crisis and transitional housing and funding those. But there's one area that we really have yet to sufficiently address, and that is related to our mental health workforce. And that continues to be the sort of nagging problem that exists in really addressing the mental health crisis. So, we really need to think about what we can do to expand capacity in our mental health workforce, just to make sure that we have enough licensed workers to meet the mental health needs of the communities, of our communities. We know that we've seen even more folks struggling with mental health issues through the pandemic, and we just don't have the adequate workforce to support those needs. We know that the vacancy rate at our community mental health centers consistently hovers around 10%. And other community behavioral health providers also struggle to find licensed clinicians to meet the needs of their patients. So a critical part is to look upstream, right? What can we do to support a pipeline of individuals who will go into the behavioral health workforce and who will stay? So just to get to some specifics about the amendment, if I may, this amendment has two parts to it, and both are critical to building this workforce pipeline that we have talked about so much and creating a pathway for professional advancement, laying that foundation for sufficient reimbursement and for this comprehensive array of services that we have built, and having qualified professionals to do that. So the two parts, we have the addition of an associate and bachelor's level social work credential, as well as a new category for conditional licensure. And the second part is this clarification of facilities under our state's managed care law and sort of the stated policy preference for facility credentialing by health insurance carriers whenever possible. The first part of the amendment related to the workforce pipeline will go a long way to reducing barriers to licensure. We talk a lot about that in New Hampshire. We have folks leaving our state because of licensure barriers. So this will go a long way to eliminate those barriers and create an entry-level mental health or social work license through the Board of Mental Health Practice. So as Senator Bradley indicated, New Hampshire is only one of a very small handful of states that still limits licensure of social workers to individuals who have a master's degree. So we're going to create this entry-level pipeline for folks to go into the mental health field. And again, this lack of licensure creates a big problem for seeking reimbursement because they don't have this license. And it's also important because we know that a lot of support services that are provided in our mental health system, these are the supports that allow individuals with very serious mental illness to keep a job, keep a house. So those supportive services we know are provided by bachelor level workers. And so we want to be sure we have a way to reimburse them for those services. So it's also important to note that creating this license, it makes New Hampshire consistent with what we do on the SUD side. So a substance use misuse disorder is a mental health disorder, right? And so we want to make sure that we have parallel license. And so this amendment does that. So I think, not having an entry level mental health license is also important to build our workforce and give folks a reason to stay in New Hampshire. So right now we're limiting the professional opportunities for individuals who want to work in the field, but who don't have time or money to go back and get their master's. So this gives a professional opportunity to folks who may not have the resources or the time to get that master's level. Again, we're sort of late to the game, so we're catching up with other states and creating this. I don't think this amendment is, the silver bullet to addressing all of our issues, but it is a really common sense but important solution to build that workforce and can really go a long way to fill some holes in our workforce. So the second part of the bill clarifies that community mental health centers, community substance use disorder treatment programs, and our community health centers, our FQHCs, are included in the definition of facility in New Hampshire's managed care laws. So this is also not unprecedented in New Hampshire. Already, our managed care organizations and our Medicaid system already credential our CMHCs, our community mental health centers, as facilities. The practice is just not as consistent with private carers. Also, many of our FQHCs are also, use this facility credential. So it's not unprecedented. It's just making it consistent across the system. So in many cases, without this way to credential the entire facility, each and every clinician at a community mental health center has to be individually credentialed with the carrier. So we have heard from folks in the community, this is really burdensome. It's time consuming again, leaves out these bachelor level workers providing really essential functional support services. So I think, it's important because the repercussions of not having this practice being consistent is that privately insured individuals are often denied the same comprehensive array of services for mental health as their peers in our Medicaid program. So we have this disparity that we need to address. So I'm going to stop there. And I'm sure there are many folks that can answer questions about the detail in the bill, but I'm happy to take any questions if people have it.
Senator Sherman or Senator Avard, do you have any questions of either Senator Bradley or Senator Whitley? Okay, seeing none. Sonia, who do we have?
We have Tyler Brannon.
Good morning, Tyler Brannon, Life and Health Director with the Insurance Department. Can you hear me okay? Great, fantastic. So first of all, we don't have a position on the amendment, and I'm speaking just to the amendment, but we do support the efforts to expand kind of the licensing and address these bachelor level providers, as well as anybody who could be supporting essentially access to mental health providers. The sort of the approach, the interest, and potentially the solution actually reminds me a bit of just before the ACA rolled out in 2014. One of the concerns we heard all the time was, well, with all these newly insured people, how are any of us going to see our primary care provider? Well, the good news is at that time, we were making use of what was considered physician extenders. So think physician assistants. There are also nurse practitioners that can operate independently. And that licensing approach effectively worked to give people additional access to those types of providers. If anything, the ACA encouraged healthcare delivery systems to make more investments on those fronts. One of the issues that came up a few years ago, and my timing on things is probably off a little bit, was just the number of physician assistants a physician could actually supervise in New Hampshire. It was limited to 4, and in comparison, Massachusetts had more flexible regulations. So that was one of the things that was addressed to give people more access. From a commercial insurance point of view, the supervising physician would bill for the services of that physician assistant, and the whole system gave people better access. So I think to the extent you're focused on changes to the licensing, allowing providers to supervise other providers, and presumably bill for them as well, all that makes a lot of intuitive sense. even our network adequacy requirements make reference to services rather than specific provider types, because we want to carry to think creatively about how they can ensure access to types of services without getting bottlenecked on the actual provider specialty or the name of the type of the provider. What we do have some concern with is page 5 and the change in the managed care law, which changes the definition of facility and includes these programs as a facility. And the concern is that these programs are clearly not a facility. So we're trying to envision what kind of unforeseen consequences this may play out as. At the risk of going into too much detail, the way healthcare services get reimbursed, there are essentially two different kinds of claims forms: a UB that is largely used by hospitals or facilities, and then a 1500 or CMS 1500 that is used by professional providers. And the history on that is largely because you had physicians that were quite independent from hospitals. But if we're revisiting the definition of a facility, are there assumptions or expectations that somehow the billing would change as well? Would these programs or types of providers start to bill as facilities? Would they be billing in addition to professional services? As a regulator, it's very difficult to interpret this change and provide a certain amount of guidance. I did hear during the introduction that it had to deal more with the credentialing side of things, which, okay, I can appreciate. We've heard problems about credentialing bottlenecks on that front, but I'm not sure this kind of change would address the credentialing the way people expect. And perhaps an alternative approach would make more sense. So I'm happy to take any questions. The first part of the bill clearly makes a lot of sense. The second one just leaves us a little bit confused.
Senator Sherman. But you have to unmute.
So that's an interesting not taking a position, Tyler, but thank you for taking my question, because that surely sounded like a position to me. But the question I would have is, this is not new. Maybe it's new to the department, but it's not too new to the other department, which is the Department of Health and Human Services, where MTOs currently are able to be credentialed as a facility. And isn't it true that at least one of our MCOs has both a commercial product and an MCO product, and their MCO product bills just fine or reimburses just fine as a facility, while their commercial product continues to do a provider-based credentialing? And isn't it also true that between the two, when you do provider-based credentialing, we have seen the information coming back from the facilities showing us just how labor-intensive provider-based credentialing is, and that if there is a standard given for who is able to do what at a facility, that it is much more cost-effective both for the provider and for the carrier to do a facility, sort of a one-stop shopping credentialing, holding the facility accountable for what happens there. Wouldn't that be an accurate, in other words, this is it true that this is not new? Isn't it true that this is more efficient and more cost-effective both for the carriers and for the facilities? And I'm not sure whether you've had much experience with the facility credentialing, so maybe you can't answer that. But I know the Department of Health and Human Services credentials their facilities in the Medicaid population.
So as a reminder, the MCOs are governed essentially by the contract they have with DHHS. The commercial carriers are governed by the commercial insurance statutes, rules, in the insurance department. So to the extent Ambetter is essentially participating on both sides of that, they would have to meet requirements associated with their contract with DHHS, federal and state Medicaid requirements. And then for the products where commercially insured people are, with any of the requirements in the insurance statute. When New Hampshire moved forward with the MCOs, we took a close look at all the Medicaid requirements, what the insurance department's role would be, and we put out a bulletin really providing our interpretation of look, we are not essentially not regulating the MCOs except beyond solvency. So what they're doing with their credentialing or what requirements they may be subject to on the facility side and the definition of facility, I can't say I'm very familiar with that. But I did take a look at where facility shows up in the insurance statute. So in other words, if you redefine what a facility is, what other things does it change? And I essentially didn't find anything. There's reference to it under the telemedicine statute, but again, it's not clear to me how it would change anything on that front. But to the extent credentialing exists as an issue, I guess my concern is just the change that's being proposed, I think is unlikely to have the outcome that the supporters are looking for. And the department would be in a very awkward position to try and tell the carriers to say, you need to do your credentialing differently based on this change that's being proposed. But I think intuitively what you're suggesting makes a lot of sense. There are a couple of things that come up with carriers when they're dealing with credentialing. And the first is that, yes, provider organizations often credential the providers that work for them. So when the carrier does their own credentialing, there's a certain amount of redundancy. The carriers are required by New Hampshire insurance law to do some form of credentialing, but there's not much in terms of requirements specified there. They're also required by NCQA, so the accrediting organization, to do credentialing. I haven't looked at those requirements for a while, but sometimes they say comply with state law. So to the extent an insurer is responsible for doing credentialing, they have some flexibility, but they also have these specific expectations. I have heard of cases, actually I've been involved with them in prior lives, where credentialing was even delegated to large delivery systems. Think one like Dartmouth Hitchcock that clearly has the infrastructure, the accountability, the checks and balances. But in those arrangements, you still have to have a carrier that has a contract in place and would hold the large delivery system responsible if there were any deficiencies in the credentialing. That being said, it clearly makes a lot more sense to credential providers as a group rather than do it on a piecemeal basis if you're looking for efficiencies. And the carriers intuitively should be on board with that. In fact, those that could do that independently, it's almost a competitive area. The carriers that do that would be more efficient than those that didn't. But anyway, so I guess the concern is not with the solution, it's with the expectations around what's there. I mean, as a regulator, we can consider legislative intent, but we can't redraft the requirements without enough in statute and enough legislative direction, I think.
I think you're muted, Senator.
Did you have an additional question?
I did. Thank you.
Just a second, Senator Whitley. Senator Avard did have his hand up about the same time as Senator Sherman did before, and then we'll get right to you.
Thank you.
Senator Avard.
Thank you, Mr. Chairman, and thank you, Tyler, for your comments. Do you have any suggestions on how to solve this problem?
Not off the top of my head, but it probably means revisiting the credentialing requirements in the insurance statute and providing some direction there. I would not go down the road of revising the definition of facility and dealing with, as I indicated, unforeseen consequences.
Thank you. Senator Whitley.
Thank you. And thank you for taking my question, Tyler. So I just also wanted to see if you're aware that, some of our federally qualified health centers are already credentialed as with our carriers as facilities. Are you aware of that?
I believe it. Was I aware of it separately? No, but I'm not sure that this, again, changes what already exists in place. I mean, clearly, if a carrier has an interest in credentialing a group of providers a certain way, then that's an efficiency they should look for. But I think redefining simply the definition of facility in the statute, it just doesn't get us there.
Follow up, if I may.
Yes, ma'am.
So Tyler, if you look at the bill, there's two parts to this section of the amendment, sort of this definitional part, and then section 8, which sort of indicates this policy preference. And so that's the legislative intent clearly stated in this in the amendment. Isn't that correct?
So I can't provide, I guess, the response you're looking for. I mean, that deals with kind of a carrier when possible, credential qualified entities as facilities when paneling and enrolling. But what makes it possible, what doesn't. I mean, is it a facility or is it not? And simply including a program under the definition of facility, I think doesn't get us there.
Follow up?
Yes, ma'am.
And thank you for that point. As Senator Bradley had indicated, we are absolutely, interested in making this work in the best way possible. So the reason why in including these entities under the definition, the community mental health program, that's the name of the program. That's how it's stated in the statute. But couldn't you see a way that we could, reference the statute, and make it consistent with the existing insurance law?
Yes, I think it's the short answer. But I think that the challenge is you're trying to deal with credentialing a group of providers collectively. Making them a facility just introduces more questions than it does answer it. So that's where I'm struggling a bit. And I mean, to me, when you draw this distinction, there's sort of licensing requirements that go with certain facilities. There are reimbursement implications that go with sort of institutional providers. Think your hospital, your surgery center, and in some controversial examples, urgent care centers that bill as hospitals, and people end up with additional cost sharing for those services unexpectedly in many cases. So to sort of credential a provider that is not a facility as a facility, that's weird. It may be intending a certain outcome that's group credentialing, but it just has potentially other consequences, and that's where I'm getting hung up. But I think to the extent that you're looking for a kind of more efficient process with the credentialing, that's certainly a worthy goal.
Okay, my last follow-up, if I may?
Yes, ma'am.
Okay, so I'm sure you're aware, but the way that these programs are described in their own enabling statutes, which are in this amendment, they do have very specific criteria. CMHCs have to meet very specific criteria to be a community mental health program as defined by 135C7. So wouldn't it be the case that we could just sort of flesh, the issues that you're concerned about in rulemaking? If we added a rulemaking provision, wouldn't we be able to flesh those issues out in rulemaking?
I don't think it's as clear as, at least I wouldn't interpret it as clearly as you're suggesting. If you look at either of them, they're both drafted the same way. It says any city, county, town, or any individual partnership, association, public or private, for-profit, nonprofit, agency, or corporation may establish and administer a community substance use disorder program. So to me, that it's still, that's very general. That could be a lot of different things. So normally, and again, I mean, sometimes agencies get accused of wanting to do too much through rulemaking. We prefer a lot of legislative direction before we do rules, because by the time we go to JLCAR, we're hoping that we're just implementing the details of something. We're not having a policy debate there.
And one last follow-up?
Yes, ma'am.
But just to clarify, isn't it true that it's the state who determines, who meets the criteria to be a community mental health program under 135C, C7? It's not just anyone who can sort of qualify. The state has to determine who meets the criteria to be a CMHC, correct?
Yes, there's a statutory definition of the program.
Yeah. Okay. Thank you.
Okay, seeing no other questions for Tyler, Sonia.
Next is Ken Norton.
Welcome, Mr. Norton.
Good morning, and committee members. Ken Norton from NAMI, New Hampshire, and very excited to offer our support. We take no position on the on HB 187 as written, but want to strongly support the amendment. And as you all know and have said, we have an ongoing mental health crisis, and workforce shortage is a significant part of this problem. And driving that workforce shortage is a focus on the medical model and credentialing, which has become, in my mind and in our mind, less about protecting consumers and more about limiting payment and protecting professionals. I offer my career as a case in point, just anecdotally. I graduated in 1980 from the University of Maine with a bachelor's in social work. I worked down the street from the State House at the Child and Family Services Group Home, making $8,300 a year. My responsibilities included intake and assessment, individual, group, and family counseling, and writing reports to the court. We were providing a residential program 24/7 to 15 teens, and we were supervised by a master's level person. I went to work in 1982 at Lakes Region Mental Health Center as a case manager. Responsibilities included treatment planning, individual and group counseling, intake assessments, and in-home crisis response and assessment to known clients, and I was also supervised by a master's level person. And then I went to UConn on the grounds in New Hampshire Hospital. We'll just mention in the musical theme of the prelude to this hearing that the only time I ever stepped foot in Connecticut was to go to a Grateful Dead concert. But I graduated, and then under 2 years of MSW supervision, took a national exam to get credentialed as the Academy of Certified Social Workers, which was the kind of terminal degree at the time in terms of billing. And then the only change during that time in terms of my job responsibilities was also assuming responsibility for doing emergency services in the hospital, which added another whole credentialing piece, which I won't get into. But then the state added licensure in, and that was then a requirement to get state licensure, which required another national exam, essay questions, submitting stuff to the state. And I would add as just a note during that time that, that as an example of how the credentialing process has gotten more difficult, during that time, master's level psychologists were able to provide individual counseling and bill for those services. But the psychologists did away with that themselves, requiring that only PhD and PsyDs were able to then provide those services. Two key points that I would like to make is that bachelor's level people have been successfully providing these services for years. It's just been limited in terms of the commercial reimbursement that's been available to them. And that also during the past 20 years, licensing and credentialing has become much more difficult. And I really question who it's protecting, particularly given the long waits that people are currently experiencing for outpatient treatment and the whole emergency boarding situation. I think this legislation will, as Senator Whitley said, establish a career path for people. We need to attract people coming into the mental health field, and this will certainly do that. And I certainly see the need for the conditional licensing piece. There have been several legislative efforts over the last few years to provide reciprocity and to speed licensing through the Mental Health Board of Practice. And apparently that hasn't worked. I've repeatedly asked for data about this. I think Senate Bill 287 in 2018, we had talked about a conditional licensing, but that had ultimately been dropped because the board had said they would be able to move things forward. And I think that we're still seeing that reciprocity from other states for licensed professionals is still a struggle, and I don't understand why that is. We also support the expanded definition of facilities. I think that it's an important step. Individual credentialing rather than facility credentialing is just another restrictive measure that doesn't really protect consumers. I believe that there are some states that require providers, commercial insurers, to reimburse any licensed professional. I don't understand why we need this dual system of credentialing. If the NCQA says that complying with state law, then why don't we just have state licensure be a universal credentialing process? And these core programs that are included in the facility definition, those are the ones that are providing the services to our most severely ill individuals and the ones where the workforce shortages are more problematic. And I also think that this, has been said, works towards parity and makes it more consistent with reimbursement from Medicaid. And then finally, with increasing demand for mental health services and demands expected to grow, we need to do something differently. I think that this will be a big help, particularly as we look to expand statewide mobile crisis response. Obviously, we'll need to get commercial insurers on board. I would note that we will need additional support to the OPLC, the Office of Professional Licensing, and the Board of Mental Health Practice in order to add on this bachelor's level piece. And I strongly applaud this proposal and the amendment and all who helped create it and bring it forward. And I think it's also particularly helpful to have the crossover with LADACs and relative to people with co-occurring conditions. And I ask you to vote SB 187 amendment as ought to pass, and I'm happy to answer any questions.
Questions from the committee members? Senator Avard.
Thank you, and thank you, Ken, for your testimony. Just with respect to the other states offering, or you had mentioned that some providers are grouped in as facilities. Do you know of the name of those states that do that?
I believe Rhode Island does. Thank you for your question, Senator. And actually, just listening to Tyler Brennan, it made me think of this. It was something that we looked into a couple of years ago, and I think needs to be looked into again. But I think that Rhode Island was one of the model states, and I do intend to follow up with that.
Thank you.
Additional questions? Seeing none, thank you very much, Mr. Norton.
Thank you, Senators.
Sonia.
Next, I believe we have Lynn Stanley.
Good morning, and thank you for hearing my testimony. My name, for the record, is Lynn Stanley. I am an LICSW. I'm a social worker, and I'm the executive director of the National Association of Social Workers New Hampshire chapter. We don't take changes to licensure lightly, and we are in support of this amendment. I do want to raise some things to take into consideration. Licensure and conditional licensure comes with increased abilities to have services reimbursed, which is why this amendment will increase access to case management and other services provided by those who don't have a master's or higher degree. It also does create a career path for those workers. But ultimately, licensure is about consumer protection. And this means that along with these new abilities, the worker also has a higher level of accountability and responsibility. The clinical supervisor is legally responsible and liable for the work of their supervisee while licensure candidates. The New Hampshire Board of Mental Health Practice will have greater oversight and ability to prescribe remediation, supervision, and tasks when there are complaints filed for misconduct. This can be a double-edged sword for the worker. The worker has licensure or conditional licensure, but this can also be taken away. The LSW tier, or the worker who has completed an accredited BSW program, is easy for us to fully embrace. The bachelor's level social worker has been steeped in social work mission and values and training with a supervised practicum. The LSWA tier poses a few more challenges and concerns. In rules, we would be advocating strongly for a rigorous and prescribed professional development track before or during the conditional phase. It would be unfair to require a new worker to ascribe to the NASW Code of Ethics with no training in the Code of Ethics or its application in the real world. We know scope of practice raises some concerns. Just because someone is allowed to provide a service in their scope of practice does not mean they have the skills to do it. For example, I have my LICSW and could diagnose someone, but I have not seen a client in over 18 years. For me to diagnose somebody today would be unprofessional and unethical. LSWs and LSWAs would be providing the same services they are currently providing, just for reimbursement. And just to really echo what Ken Norton previously said, they're already doing this work. Supervisors, as stated before, the clinical supervisor would now be legally responsible for the actions of their supervisee, including if the LSWA or LSW candidate was providing a service they did not have the training or preparation to provide. We believe that this provides necessary guardrails to protect consumers. The LSW and LSWA tier workers can provide case management and counseling. They cannot diagnose or provide psychotherapy. We hope the addition of these licensure tiers might provide a piece of the puzzle to increase clients' access to services. I thank you for your time, and I'm very happy to answer any questions you may have.
Questions from committee members? Seeing none, thank you very much for your testimony. Sonia.
Next, we have Sabrina Dunlap.
Welcome, Ms. Dunlap.
Hello, how are you?
Good.
All right, thank you. Thank you, Senator Gray and members of the committee. My name is Sabrina Dunlap. I'm Director of Government Relations at Anthem, and thank you for the opportunity to testify on the amendment to HB 187. So, I guess I'll start by saying, as many of you know, we and many others have been at the table the last few months really trying to work through these complex mental health issues we have in New Hampshire. And I really appreciated hearing Senator Whitley's comments at the beginning. I mean, we agree the workforce issue is very real and something that needs to be addressed. And I really appreciate the comments about pipeline and increasing career paths. That makes a lot of sense. I will just note at this point, I do hope our conversations continue. I think there are some actions that can be taken sort of more immediately that are outside the legislative setting. So I do hope that we continue to have those meetings and continue those conversations. I do also just want to note quickly, there's a lot of, I guess, conversation about whether or not commercial carriers credential facilities. And I do just want to know, I think it's a little more nuanced, and I know Senator Whitley recognized this, but it's a little more nuanced than saying no commercial carriers cover lower level degrees or bachelor level degrees, because Anthem does. I know at least with our CMHCs, we credential the facility, and bachelor level and non-licensed workers their services are covered currently. So I did just want to flag that. As for the amendment language itself, we have some concerns related to the scope of services and the new tiers of social workers, and some concerns with the facilities that I'll get to. But first, for the first tier, the licensed social worker, it's not clear to me why the supervisory component would go away after 2 years. It does seem like oversight for clinical work at that level would be reasonable, and I'm just not clear on why that would end after 2 years. And then regarding the second tier, the licensed social work associate, we are concerned with the broad scope of what to us seems like clinical services that are included in that section. And I do appreciate Lynn's testimony. That was really helpful to hear. But maybe we could get a little more clarity, because based on some of the research I did, it seems like the Council on Social Work Education, the CSWE accreditation, is required for licensing in most states. So this associate tier not only creates a license without that accreditation component, but it seems to give this level of social work clinical responsibilities too. The language in that section says the category allows for counseling, including individual, group, family, and significant other counseling. So I'm just not clear on how that wouldn't sort of get into the clinical realm. And I asked our behavioral health team if they were aware of any other states allowing clinical work for this license level. And even with supervision, they said the answer is no. So for that level, that lower level tier, we do think that a more appropriate scope would be keeping their scope within case management and treatment planning and that sort of thing, but not counseling or clinical work. And then the last issue I want to flag is related to the facilities. And I know we heard from Tyler, and I agree largely with a lot of what he said. So I would also flag concerns with changing the defined term of facility. I mean, it's used throughout RSA 420, and I think changing the definition could have unintended consequences for the rest of that statute. And I do think changes can be made in Section 8 to the amendment to achieve the intended effect without changing the definition of facility. And the way the amendment's currently drafted, I mean, I read it as requiring carriers to change their approach to every facility listed in that definition, because the new Section 8 says carriers should credential on a facility basis with every facility. And that would include far more than just the new mental health entities added to the definition section. So it seems like if the goal is to have CMHCs and community mental health centers credentialed as facilities, maybe instead of changing the definition of facility, we could combine or modify Section 8 to say, where possible, carriers will credential CMHCs on a facility basis. And finally, I know there's a lot to unpack on this, so thank you for me. Related to the facility definition section, I would also flag concerns with the changes that include programs as facilities. I would echo what Tyler said. I talked to our BH folks and our medical director, and they said that there's just a clear distinction between actual facilities, which are the structures with the materials and the location to service the condition, versus a program, which is the process that provides care at the facility. So I think trying to force programs into the concept of facilities might not work as a practical matter. So in closing, I'd say we understand and agree with the good intentions behind this amendment. I think the amendment, though, is quite expansive, and so we'd respectfully request that the new tiers of licensing have tighter and, I think, more appropriate parameters, and hope we have further discussion and clarification on the scope of services issue. And we'd also respectfully request our suggested changes to the facility issue be considered. So thank you very much for your time, and I am happy to take any questions.
Questions from committee members? Seeing none, thank you very much for your testimony. Sonia, how many more people do we have on the list?
We have 3 more people on the list, but we have 4 hands raised.
Okay.
Next is Donald Funstein.
Excuse me. Thank you, Mr. Chairman, members of the committee. I am Donald Funstein from the Gallagher firm. I have the pleasure of working with my colleague Heidi Kroll in our representation of AHIP, the health plans. I would just like to make a few points. I know you have heard a lot already. Senator Bradley, when he introduced the bill, or amendment, excuse me, mentioned the importance of the entry-level bachelor position. And certainly we wholeheartedly support that. I would simply like to make the point, though, that the draft that Attorney Merritt prepared for you includes associate level staff people throughout the draft for both a social work license and perhaps a little bit more interesting from a review perspective. It's the same for the conditional license. So you would have a conditional license issued by the state for up to 4 years for an individual who has completed an associate's degree. And I just think that you should be aware of that if you're not already aware of that, because the draft does that throughout. The other area that I'd like to touch on is one that comes up repeatedly, and that is the area of facility credentialing. In the Medicaid context, the managers of the Medicaid programs here in New Hampshire tell me that the credentialing of a facility, and that is what's referred to as delegated credentialing. And the carriers use and go to facility credentialing when you have a well-established organization that is professionally staffed and similarly professionally managed, so that one becomes comfortable quickly with the rigor of the internal credentialing done by the facility of its employed providers. And that is, I am told, not really the standard, but in fact is done on an episodic basis, depending upon the nature and circumstances of the facility. However, when you look at, say, a smaller group of providers that may not necessarily be long and well established, may not be even known, frankly, to a lot of the companies, and not have, of course, the resources and staff that the larger, more established facilities would have. In that circumstance, we would suggest that being forced or encouraged to use a facility-based credentialing as opposed to a provider-based credentialing, really wouldn't seem to be furthering patient safety. So that is something that has been explained to me in response to our report of yesterday's meeting with Senators Whitley and Sherman, for which we are very grateful, because it gave us an opportunity to better understand the amendment, which we were poring over that weekend. The other point briefly I'd like to make is in the area of the conditional licensing. We think it would be necessary to tie the conditional license of the social worker associate into the clinical supervision requirement on line 26, I think page 3, just to make it clear that someone who was conditionally licensed would also be subject to the requirement that they be working under clinical supervision. Again, it's just a drafting issue. We also thanked Senator Whitley for her invitation to come up with a proposed language that would address some of the issues we shared with them yesterday morning. And I can tell you a group of us have been doing that since we last spoke with you. And hope we continued last night and we'll stay at it. And I'm sure if we're given the opportunity, we'll have something to the committee shortly. And with that, I apologize. I looked for an appropriate quote from John Jay or one of the other founders, but I couldn't find one. But with that, I'd be happy to answer any questions you might have.
Other questions from the committee members? Seeing none, thank you very much. Sonia.
Next is Michelle Merritt.
Welcome, Michelle.
Thank you very much, Mr. Chairman and honorable member of the committee. I appreciate the opportunity to speak with you today, specifically on this amendment. Like several others, I'm not speaking on the underlying bill, HB 187, but I am speaking to Amendment 1242S. So New Futures, I'm the president and CEO of New Futures. For those that aren't familiar with our organization, we're a nonprofit, nonpartisan health policy and advocacy organization in New Hampshire. And we've worked extensively with policymakers, care providers, and families to address behavioral health issues facing our state. And again, we stand in strong support of this particular amendment. Admittedly, I did have ongoing conversations with several committee members in the drafting of this amendment, and appreciate the support of those that worked with us. New Futures came to this issue through ongoing work that we were doing over the past several months with a broad group of stakeholders to address the alarming rise of children who are being boarded in hospital emergency rooms across the state while they're awaiting acute treatment for behavioral health conditions. Through our collaborative efforts, there were several issues that were identified that were compounding the ER boarding crisis, and they primarily were a lack of workers to provide essential mental health services, a need for a really clear pipeline for workforce development, bring people into the profession, and some consistent problems with reimbursement for bachelor's level mental health workers. It's our position that this amendment goes far in addressing each of these issues. So I want to take the two sections of the bill in turn and also answer some of the questions and comments that had been raised earlier. So in terms of behavioral health workforce pipeline, this is creating a pipeline through licensure is not a new concept for social work professionals, in particular, as Senator Bradley mentioned, 38 other states, 5 US territories, including in Washington, DC, do offer a bachelor's level license in social work. I would also mention that there are several other states that also offer associate level licensure for social work. New Hampshire's own board for licensed drug and alcohol counselors has a similar licensure pipeline with associate level licensure for addiction treatment professionals, that is the LADAC. The structure that you see within this bill, particularly for the LSWA, mirrors almost exactly what is set up within the LADAC statute for those professionals. So without a bachelor's level credential or an associate level credential, it's very clear that there's a lack of parity with what happens for other behavioral health professionals and licensing of those individuals. It also creates some significant reciprocity issues for those that are licensed, that hold these licenses in other states, for not being able to come to the state of New Hampshire and have a license available to them. So from our position, this is a common sense solution, and it would undoubtedly increase the number of professionals available to meet New Hampshire's growing demand for service. New Hampshire, in our estimate, could reasonably expect, as a result of these changes, to see about a 50% increase in the number of clinicians applying for licensure by introducing these 2 entry-level credentials in this amendment, as well as conditional licensure. New Hampshire's university system alone matriculates an average of 80 bachelor's level students in social work, all of whom would meet the minimum criteria for conditional licensure as an LSW upon graduation under this structure. With the vacancies that we see at community mental health centers, which is around 200 or so clinical positions, even a modest influx in the number of workers through this new licensure pathway could be transformational for the health system. So to address a couple of the issues before I move on to the reimbursement for bachelor's level mental health workers in the section that deals with the managed care law, there was a question around the LSW and supervision ending after 2 years. I will say this is model law. This is consistent practice of other states that have LSWs. The LSWA is the one that requires ongoing supervision, even post-licensure. There is a national board of National Association of Social Work Boards that does provide that, and it's very clear that after 2 years of supervision, the LSW has the ability to practice independently. That's with a caveat though. Even master's level clinicians, it's worth noting, have ongoing requirements in rule for case review. So they meet with colleagues and discuss cases regularly. That is a level of supervision and collaboration that's embedded in all of our behavioral health credentials. So it's not as if these individuals have free reign, independent, have no further accountability. They do have that ongoing requirement. Again, the LSWA is not unique. There are several other states that offer this. It mirrors the LADAC that similarly has an associate pathway in it. It's worth noting, because it was mentioned, that there is a, it's called the CSWE. It's an accrediting body for social work programs at universities. The reason why that's not specifically listed in here is because the CSWE does not accredit associate level programs. There is, however, through the National Association of Social Work Boards, an entry-level associate exam. So again, just to stress, this is consistent with model law. It is consistent with what is available for licensing supervision requirements in other states. And I would strongly encourage the committee to maintain the existing structure. The only thing that I would say is an oversight that came to our attention late is when we were looking at the conditional licensure pieces, we did leave off one of the credentials, the school social worker, that we would suggest adding that as well. So beyond the creation of the pipeline for social work professionals, the amendment would also have the impact of creating new opportunities for reimbursement of services delivered by bachelor's level workers. Without a license and a very clearly defined scope of practice, there are a few circumstances in which, from what we were hearing from community mental health centers and others, that private insurance would reimburse for the services delivered by those workers. Creating opportunities for licensure clearly addresses this issue and would allow for greater reimbursement in a wider variety of clinical settings. The last component of this amendment, we believe, provides clarity to the New Hampshire managed care law. I will say that I'm not necessarily wedded to how this is structured. I'm willing to talk to others who understand what the underlying objective is and figuring out how we might be able to do that together. The general idea, again, is to create flexibility and parity with regard to facility credentialing for mental health centers and similarly situated care providers within the private insurance context. Instead of carriers credentialing clinicians individually, which, as Senator Whitley mentioned, is burdensome, time consuming, and ultimately has the impact of excluding certain services rendered by bachelor's level folks in the array that's available to privately insured individuals. We can address that through some facility licensing and clearly articulating the state's preference for carriers to designate these entities as facilities whenever ever possible. The last thing that I do want to address was a concern that was raised by the insurance department about contemplating these changes and the intersection with NCQA. When we were looking at this amendment, we specifically engaged the policy team at NCQA to ask this question about CMHC designation and credentialing as facilities. And they were fairly clear with us that this is permitted, that for NCQA health plan managed behavioral health organization credentialing accrediting programs, community mental health centers fall into the category of an ambulatory behavioral health care facility and are assessed as hospitals and others under CR7. So I just wanted to very quickly address that issue as well. But again, stress, we are open to working with others to ensure that the underlying intent of what we're trying to achieve here ultimately comes to fruition. So with that, I'll stop and I'll answer any questions that folks may have.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Michelle, for your testimony. Because I'm not entirely familiar with the NCQA process and how it relates to this issue, can you give us a little overview about of that for us and how this sort of gels with what we're trying to do here?
It may be easier, instead of me trying to explain it, for me to shoot you over in my testimony the summary that I received from NCQA on this particular issue for you to sort of weed through it on your own.
That'd be great. Thank you.
Yep.
Additional questions? Senator Sherman.
Hi, Michelle. Thank you for your testimony. Just a quick question. Where did you want, did you say school social worker? Where did you want that?
Yes. So NASW and myself had ongoing conversations when this amendment was being contemplated, and it was caught late that in the list of conditional licensure categories that the school social worker is a credential that exists currently, but was not included in the conditional licensure category. So I would suggest heeding their request and including that.
Quick follow-up?
Yes.
Yes, sir.
So it is included on page 1, line 11. Where did you want that inserted? I'm sorry, or do you want to?
It's under the conditional licensure piece. It was not in there.
Okay.
So that would be.
Oh, I see. That's on page 3 at the bottom.
Yes. So page 3 into page 4, we list out clinical social worker, licensed social worker, the LSWA, they're missing from that list is the school social worker.
So that's lines 27, 28.
Yes.
Okay. Thank you.
Additional questions? Seeing none, thank you. Sonia?
Okay. Next is former Senator Bragdon.
Senator Bragdon.
Thank you very much, Senator, and thank you, committee members. By the way, love the bumper music before the hearing. I think that should be a requirement of all hearings going forward. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, New Hampshire's only not-for-profit health insurer, an insurance company founded by doctors, providing health coverage for more than 100,000 of our friends and neighbors here in New Hampshire. Harvard Pilgrims takes no position on the amendment. Right now, we're just trying to understand exactly what it does. I've been taking furious notes here for the last hour or two. We weren't involved in the creation of this and just saw it on Thursday. So I guess that leads into my main request, and I assume this is the case, but it hasn't been stated directly, hoping the committee does not exec the amendment and the bill right away. There's, I think, 3 weeks until the deadline for execing bills. So we'd be happy to be part of any conversation about the amendment, certainly understand the issues at hand and some of the things that are looking to be addressed. A couple of areas of interest that we have. One is, in certain cases, there seems to be some broad and subjective language. For instance, on page 5, line 16, which is that new section that talks about in the managed care laws, it says health carrier shall, whenever possible, credential qualified entities. And the terminology, whenever possible, is maybe a little too broad and subjective, and qualified entities may need some more definition just to be clear. And I think there's been some suggestions of perhaps other ways to do that, and be happy to participate in that conversation. Another thought was, and it's been discussed kind of a couple times here, is does including programs like the community mental health programs under facilities in the statutory scheme introduce other requirements we need to consider, some unintended consequences. I'd point out, based on some of the previous comments, that treating a program like a community mental health center like a facility internally, for instance, delegating credentialing to a program, is much different than including it in the statutory scheme. So I think we understand what's trying to be accomplished, and I think it's been suggested there might be other ways to do it that don't potentially cause other issues later on. And then finally, we just want to take more time to look at the supervision, education, experience requirements, as well as the scope of practice, just to see how that meshes with everything else. So that's more a matter of time. So like I said, be happy to be part of the conversation, and hoping that they don't plan to exec this right away. And thank you for your time. I'd be happy to answer any questions.
Questions for Senator Bragdon? Okay, seeing none. Thank you. Sonia, are we back to one person now?
Yes, our last speaker is Representative Edwards.
While he's getting ready, if there's anyone else that wants to raise their hand, you better do it now, because as soon as he gets done, if there's no hands, I'm closing the public hearing on the amendment.
Hello again, Senator. Again, for the record, I'm Representative Jess Edwards, representing Auburn, Chester, and Sandown. I've been listening into the testimony today. I've not I've not read the amendment, so my comments are really very limited to the point that I think we all agree that we have a serious workforce problem, and it's great that everyone's focusing on trying to expand that workforce, and building a career path would be, I think, a great way to do that. I would just encourage you to think about the history and development of the physician assistance program. I have some experience with that. My dad helped establish that at the University of Nebraska Medical Center over 50 years ago. And the PA programs at the time were designed to create bachelor's level graduates that were prepared fully to enter clinical practice under the supervision of a physician. And so that history, I think, would help inform the decisions that need to be made relative to the amendment around, to what extent do the bachelor's programs as they stand today truly prepare practitioners, clinical practitioners, as opposed to whether or not they were designed to prepare people for graduate work. And in the case of the PAs, the program was built to create clinicians. And I just wonder if retrospectively, if we're adding the bachelor's work to a clinical certificate, whether or not we're putting the cart before the horse. I'm not an expert on those degree programs. I would just say that's something that should be verified. I heard one person testify today that suggested those programs were built to produce clinicians. I would just encourage you to check it. And then based on the level of preparation, the scope of practice, as the Honorable Peter Brigden just mentioned, I think would be critical to roll out. And I did hear that the supervision role, the clinical supervision role, was only to last for 2 years. And initially, until PAs got really, really proven, that clinical supervision piece didn't really go away. And I don't know that PAs today can do independent practice. I think for the most part, they still have to operate under the supervision of a physician. And so my point in saying anything and taking more time of the committee was just to point out that we have some metaphors, some analogies of how the healthcare credentials have been expanded and added to, and some of the decisions that were reviewed and made at that time. So that was really the point of my commentary. Thank you for the time.
And thank you for your testimony. Do we have any questions for Representative Edwards? Seeing none, Sonia?
I don't see any. No, I don't see any hands.
Then we'll close the public hearing on the amendment, and we'll turn this back over to Senator Bradley with one suggestion that he ask Senator Whitley, and with your assistance, to come up with a Bradley special on this amendment. And I think there's a lot of good ideas out there.
Only if we call it the Whitley special.
All right.
I like the idea of the bumper music.
Okay, thank you very much, Senator Gray. So what I'd like to not suggest, but ask, and hopefully the Miss Merritt, Sabrina Dunlap, and others work with myself, Senator Whitley, Senator Sherman, Senator Avard, Senator Gray, to, bring together some, a viable way of going forward on section 7 and 8, as well as if there is a need, and I'm not sure there is, to address the scope of practice is too broad, to enter into that as part of the discussion. So we don't have to exec this bill today. We're not going to, obviously, but time is of the essence. So I'll leave it to Michelle and to Miss Dunlap to try and structure a time that some of us, at least the senators, can participate. Okay, does that make sense, everybody?
Yes, sir.
Yep.
Okay. Senator Avard had texted me that you had to leave fairly soon. Do we have time to go into exec or not?
I'll motion to move into exec.
I guess that means we do. Okay. All in favor of the motion, Senator Sherman,
Yes.
Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Avard,
Yes.
and I vote yes. All right, we're in executive session. Let me just yes.
We heard Senate Bill 143 this morning. There was only 2 people testifying. They were very much in favor of it. It's the bill that does the making sure that opioid prescriptions, et cetera, are done electronically. Seemed broad support on that. So I would move ought to pass.
I'd like to review the testimony of that, Senator Gray. If we could just sit tight on that one for a week, that would be good. Let me just review what we have first. We have 350 qualifying patients to cultivate marijuana. I know that Senator Sherman has an amendment on that. Senator Sherman, do you have an amendment on 479? My notes indicate that you were going to bring one in.
Just one second. I'm going back to the 479 is the, you know, I still haven't heard back from the board. So we could go ahead, and if we need, the only issue was whether PAs could participate. And if you're anxious to get that.
No, I'm just curious, that's all. And the same thing on House Bill 146, ingredients in injectable. You were in theory going to have an amendment on that.
Actually, I would rather not see that move forward. So that's
okay. All right. Okay.
I just don't think it's necessary.
All right. And do you have an amendment on House Bill 572?
We will. We actually do. We met yesterday. It was a great meeting. Everybody came to agreement. We have the language. It's just Bruce Berkey wanted to take it back to his association. So we're
all right. So
supposed to
that
hear
one's
from him.
ready to go. All right. So
But that'll be ready for next week for
next
sure.
week. All right. So here's what I'd suggest, because we don't have a lot of time. Why don't we look at 350 and see if we can exec that bill? Okay, that's qualified patients and designated caregivers to cultivate homegrown cannabis.
You have an amendment to that, don't you, Senator Bradley? I have one here that has your
I
name
don't.
on it. 0862S.
All right, maybe it can be put on the screen. I suspect that there'll be a motion either to re-refer or ITL the bill, but let's go through your amendment.
Mine? Yeah, there. I have one from you as well. I don't know. Maybe that's defunct. Mine is very straightforward. It is Amendment 0972S. And this is at the request of dispensaries. And what it does is, I'm just going to read this. The department shall provide each qualifying patient and designated caregiver who reports cultivation location in accordance with RSA with information on the potential risks of contamination associated with home cultivated cannabis, and shall recommend that home cultivated cannabis be tested by a laboratory for contaminants. It's just a disclaimer. You can see that down in this.
Okay, it's on the screen now.
Yeah, so it is a request by the dispensaries to put in a warning when people do home cultivate that there is a risk of contamination, and that the safest way to do that is to make sure that any products that you're home cultivating are tested for any contamination.
Okay, so my sense, Senator Sherman, is that the bill may not go forward, but if it does go forward, this is a good amendment.
That was my sense as well, Senator.
So, you know what, Senator Sherman has moved the amendment. I'll second it for purposes of discussion. And I'm assuming Senator Sherman has already made the ought to pass motion, so that's where we're at. Okay, any discussion on the amendment?
This is Senator Gray. I am not a proponent of grow your own, whether that's medical or other. I will support the amendment, but if the bill comes forward in that form, I will not support the bill. But I think that it does if the other senators approve the bill, I think that this improves it.
Okay, so I'll call the roll on the amendment 972. Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Avard,
Yes.
and I vote yes. All right, so I'm going to recognize Senator Sherman for a second motion. I'm assuming it's ought to pass as amended.
Correct.
I'll second that.
And I'd like to speak to my motion if I could.
Okay, go ahead.
This, we've seen this process before, and we heard it last biennium. And essentially, the bottom line is that there are benefits to home grow. The benefits are, one, accessibility of the therapeutic cannabis. The second one is the ability to adjust the therapeutic cannabis to your specific needs. And the third one is cost. I would put into that this is a much lower cost option for the patient once they have the plants. And so it is, the concerns that people have expressed are the concerns for abuse and resale and all those. There are significant penalties attached to that. I would also recognize that this is not talking about recreational marijuana, although we are surrounded by states and a country that do allow recreational marijuana. So what I see this as is really a patient-friendly extension of the ability to access the therapeutic cannabis program in a way that does provide significant penalties if there's abuse or diversion. And I really don't see any demonstrable downside. Maine has had this since they first instituted therapeutic cannabis, and they have no documented problems with their home grow option. So, we are not, Senator Gray actually alluded to home grow for recreational. That's not what this is. And I know he wasn't saying that. This is a completely different issue. This is whether we fully support our patients who are in the therapeutic cannabis program with something that increases accessibility for them, decreases cost for them, and allows them to adjust the product to meet their needs. And now also has the disclaimer, the precaution to watch out for contaminants and encourage testing of the product. So I hope I can get at least 3 votes out of the committee so that this can move to the floor of the Senate for a more robust deliberation.
Senator Whitley, more robust, just deliberation.
Thank you, Mr. Chair. And, I respect my colleagues' comments about patient care. And I think that this bill and the amendment appropriately addresses, keeping our patients safe, but also allowing them to access something that they so desperately need. So for me, it's all about making sure patients in this program, we have the program, so we have to make sure that these patients have access to this treatment that they so desperately need. We hear these stories. So for me, it's all about, we have this program, we got to make sure that folks can access it.
Senator Avard.
Senator Avard, I'll be voting against this. I do believe that it'll probably have a bad impact on our ATCs that we have out there. I think also it is rife with the potential abuse and black market stuff. Yeah, I believe that can happen. I also believe you're changing one liberty for another, and I think that people aren't aware that their Second Amendment may be in jeopardy if they either get their medical marijuana card or they start growing their own. I do believe that is a potential consequence. And I don't know of any other scheduled C drugs or any other drugs that you're allowed to grow at home or manufacture at home. Anything that, it just doesn't make sense to me. I think it's a bad way to move forward. And I think I'd definitely be voting no, so.
Okay. I guess since everybody else has said something, so will I. I am torn. I'm going to be voting no. However, if the change that we made from making therapeutic cannabis dispensaries for profit doesn't help to lower the cost of medical cannabis, then I will make it clear I may reconsider at some point in the future. So having said that,
Could I just
Senator
say
Sherman.
just one point to Senator Avard's? I just remind the committee that the source for these plants is from the dispensaries, and they are on board with this. They are supportive. So I can't speak to your other objections, but that one I think is they do understand it. They are going to be selling the plants, and will be participating in the process. So.
If I may add one more thing, then, Senator Gray brought this up as well, and so has Senator Gary Daniels in the past, I believe, that, until the federal delegation makes this available without consequences, being a felony or a potential felony, I think it changes one liberty for another. And I think that the federal delegation needs to do something about this, because there's a federal law and then there's state law. And I think it does a disservice to the people.
Okay. Seeing no further discussion, let's call the roll. Senator Sherman,
Yes.
Senator Whitley,
Yes.
Senator Gray. You're muted.
I'll try that again. No.
Senator Avard?
No.
And I vote no. Senator Gray, you want to take this one out?
You need
You
another.
don't have the right motion to take it out yet, Senator Bradley. You need.
Oh, you're right. I'm getting ahead of myself. So the motion of
ought to pass.
ought to pass fails.
In deference to you and wanting to know how the law change that we made previously, I'll move to re-refer.
I'll second.
Okay. Any discussion on that motion? Senator Sherman?
I'm going to vote against it only because I don't think I think it's ready for ought to pass. So
I'll be with
Okay.
Senator Sherman on that.
Okay, so the motion is re-refer. We'll start again with Senator Sherman,
no.
Senator Whitley,
No.
Senator Avard,
Yes.
Senator Gray,
Yes.
and I vote yes. Okay, now Senator Gray can take it out.
And
Okay.
I will speak to it on the floor.
Oh, I'm sure you will, robustly.
Robust. We'll have a robust deliberation.
All right. Senator Avard, do you still have time to go through a couple more bills, or are you pressed? You're muted.
If we can do one quickly.
You know what, why don't we just sit tight and why don't we start at 9:30 next week? Senator Sherman has promised a couple of amendments. I'm not sure that 220 will be ready or 187 will be ready, but we'll see where we go. Okay? Does that make sense to everybody?
Thank you.
All right,
Thank you.
so Senator Avard moves we come out of executive session. It's seconded by Senator Sherman. Senator Whitley,
Yes.
Senator Avard,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
and I vote yes. Senator Avard moves that we adjourn. Seconded by Senator Whitley. Senator Whitley,
Yes.
Senator Avard,
Yes.
Senator Sherman,
Yes.
and Senator Gray. Okay,
Yes.
9:30 next Wednesday. No hearings, just exec session. Everybody that has amendments, try to get them to Kirsten early next week. Okay?